Good morning. I hope you're all doing well today. I'm going to be talking a little bit about post-COVID syndrome. Um, Disclosures, I have none technically, although I will let you guys know that I am currently working with the UW Post-COVID Clinic. Those who are Roosevelt residents know that I already really generally like chronic fatigue syndrome and myalgic encephalitis. And most of my presentation will be a little more focused on those that are non-ICU survivors. But at any time during today's talk, if you want to interrupt me to ask questions or want to put things in the chat, please let me know because I'm totally fine with being interrupted. The goal for today is to help really explain the prevalence of delayed and long-term symptoms associated with patients with post-COVID syndrome, describe some of the symptoms related to post-COVID syndrome, discuss management, and outline sort of the importance of our current interprofessional team approach to management and review some treatment options. So we're going to start first with a case of a real patient that I took care of as part of the post-COVID clinic. This was a 30-year-old woman that was referred to me. She had no past medical history and was supposed to be evaluated for post-COVID syndrome. Unfortunately for her, she had tested positive for COVID both in March 2021 and then developed a second infection again in July. Both times she had pretty mild symptoms, some intermittent fevers, fatigue, congestion, headaches, sore throat, myalgia, and then a little bit of dyspnea with a non-productive cough. The second round of her COVID was much worse than her first round of COVID. But when I saw her in September of 2021, at this point, she had developed pretty persistent fatigue, brain fog. The myalgias hadn't gone away, and she was having a fair amount of palpitations, difficulty focusing, and a fair amount of dyspnea on exertion with a fair amount of cough as well. So while it's not well defined, post-COVID syndrome is currently sort of characterized by a broad range of symptoms, including both physical and mental, that develop during or after an acute COVID infection and continue for at least a minimum of 4 weeks beyond that acute infection, not explained by an alternative diagnosis. The post-COVID clinic at Harborview currently says 3 weeks as their definition. And then if you look up the WHO, I think the WHO is currently defining it by 2 months as opposed to 4 weeks. Post-COVID syndrome is much more common than you might think, and per current studies affects as much as 10 to 35% of folks who've had a COVID-19 infection, and that's primarily looking at outpatient cases. If you look at inpatient cases, it's as much as 85% of folks who are hospitalized with COVID that might have post-COVID syndrome. And not surprisingly, it disproportionately affects women and people with multiple comorbidities, primarily women in their 30s and 40s who otherwise might be at risk for autoimmune disease. This is sort of an old statistic now, but as of March 2021, about 114 million Americans had been affected by COVID. And so at that point, about 10 to 15 million were thought to be affected by long COVID. So it might be significantly more now about a year later. The big reason that this is important is the majority of patients with long COVID end up presenting to primary care folks like yourself and have a lot of increased needs for follow-up. So what is post-COVID and what is sort of the expected etiology? I wish I had a better explanation for this for you guys, but at this point, this is not particularly well known. So post-COVID syndrome is pretty heterogeneous and can be attributed to a lot of different underlying pathophysiological processes. There's a lot of research underway to characterize and differentiate the different types of etiologies. This is essentially for example, organ damage resulting from acute phase reaction, complications from persistent hyperinflammatory state, ongoing viral activity associated with the viral reservoir, inadequate antibody response, and many other causes. Factors that sort of further complicate the presentation of post-COVID conditions include like if the patient had any sort of physical deconditioning at baseline, or any sort of prolonged acute disease course that can be non-specific to COVID or pre-COVID morbidities, or any sort of other physical or health consequences that sort of played a role before the patient had COVID. There's also multiple onset patterns for post-COVID conditions that have been identified, including persistent symptoms and conditions that begin at the time of the acute COVID illness, or new onset late sequelae following an asymptomatic disease or a period of acute symptom relief or remission, or the evolution of symptoms and conditions that can include some persistent symptoms like shortness of breath with addition of new symptoms like cognitive difficulties. We've also seen that many of these presentations are pretty similar to things you guys might already have seen, like post-EBV syndrome, post-Ebola syndrome, or other viral illnesses. And sort of is similar to myalgic encephalitis, chronic fatigue syndrome, other types of dysautonomia, or mast cell activation syndrome. Many of these have been reported in patients who had other types of COVID infections like SARS or MERS. So that's sort of the best evidence we have thus far. In terms of symptoms, COVID essentially, or post-COVID syndrome essentially can present any way it wants to, but the most common symptoms are fatigue, dyspnea, chest pain, and cough. And as you can see here from the statistics, the range is massive, from anywhere from teens to up to 87% with the fatigue. So we don't really have great data yet. Other symptoms that are physical include things like headache, palpitations, difficulty breathing, loss of smell or taste, which you guys are probably pretty familiar with, paresthesias, a lot of GI issues, skin concerns, joint pains, autonomic dysfunction, muscle aches, and hair loss is another one that I've seen a lot of. And then similarly, you can get a lot of psychiatric symptoms as a result of post-COVID syndrome. As again, you can see here, things like anxiety and depression affect about 1/4 of folks, similar to sort of PTSD. And then brain fog, which presents in sort of two different ways, either more sort of poor memory and concentration or impaired concentration specifically. Unfortunately, again, based on this wide differential of the percentages, these all come from observational studies, and the prevalence and severity of post-COVID syndromes had significant methodological limitations, such as lack of control, population selection, reporting bias, and a lot of standard assessment protocols. So again, this is like very, very preliminary data, but sort of the best we have at this point. The one thing that is pretty consistent across all of the articles and papers that have been studied thus far is that having post-COVID syndrome reduces quality of life by as much as 50% for the majority of people that end up with the syndrome. So it is quite impactful and significant on their lives. All right, so back to our patient. So she, in terms of medications, was just on a multivitamin. In terms of allergies, just both with drugs. Family history, mom and dad had diabetes and hypertension. She had a maternal grandmother with breast cancer, but nothing too significant or relevant to today's case. In terms of social, the things that are most important is that she was a very avid runner and really has not been able to run at all since getting COVID back in March of 2021. She also works as an engineer for Boeing, primarily at home, but has had to cut back on her hours to about half of what she was doing previously due to significant cognitive issues. On exam, her vitals were notable for a slightly elevated heart rate of 101, but otherwise a normal blood pressure, temperature, and oxygen saturation. Her cardiovascular exam, besides being mildly tachycardic, was regular, no murmurs, rubs, or gallops, and she had no lower extremity edema. Her pulmonary exam was normal, and neuro, she was alert and oriented. Her mini-cog was normal. Cranial nerves were grossly intact, as was her gait. but she had some dizziness upon standing, although otherwise orthostatics were technically negative. So what are some things you guys are thinking about on your differential? Would you guys be willing to put some things in the comments for me? So we all know that sort of the anchor of this is post-COVID syndrome, but I don't want to miss other things. So what are you guys thinking about? Depression, anemia? Yes, absolutely. Hypothyroidism, you guys are brilliant. Are those the only three you guys are thinking about? Nothing else? Really? All right, there we go. Thank you. So cancer, I love it. Pulmonary embolism. Absolutely. Anything else? Pregnant? Yes, totally. Thank you guys for your participation. So in general, the most important thing that folks like myself that work with post-COVID patients need to do is rule out other causes of their symptoms. And things I think about are generally hypothyroidism, which you guys totally narrowed in on, anemia, absolutely. I generally think a lot about vitamin deficiencies in these folks. That's things like B12 deficiency, iron deficiency, or vitamin D deficiency, which we all know we have here in Seattle. I think about maybe different types of viral causes like HIV and hepatitis. Again, these are low risk, but things you don't want to miss. Sleep apnea, if again, the person has sort of the right body habitus, something to think about in terms of explaining their fatigue syndromes. Remember, autoimmune disease absolutely presents in folks in their 30s to 50s. And this patient is like right in that population where she could be developing autoimmune disease. If she was a patient that I saw in clinic who wasn't quite as far out from her initial illness, I might think a little bit more about bacterial pneumonias or post-viral cough. Although less likely in this case now that we're sort of looking at this case about a year from when it actually happened. And then I think a lot about is there any sort of baseline psychiatric disease, primary pulmonary disease, or primary cardiac disease. And then Will very appropriately pointed out the patient could be pregnant, which I did not include in here, but is absolutely a very reasonable thing with a female 30-year-old patient to think about. So workup. So there is no good data for this. This is 100% based upon my experience, what I've seen my colleagues do in the post-COVID clinic, what I've seen rehab medicine do in the post-COVID clinic. And there are a couple articles by the CDC and the Lancet that talk a little bit about some basic labs to get. But sort of based on your differential, I typically think about it's important to get a baseline CBC, CMP, a thyroid TSH plus minus T4. And then I typically, again, to rule out vitamin deficiencies that are very easy to treat as common causes of mood symptoms or depression, getting a ferritin, a B12, and a vitamin D. The ESR and CRP are a little bit more controversial. Some studies say absolutely please get these as part of your workup to make sure you're not missing the autoimmune causes. Others say specifically just to get an ANA instead of those two. But that's sort of a common thing that most folks have done as well as part of their basic workup. And then most additional workup beyond this is a little bit driven by patient symptoms or sort of primary patient complaints. So if you have a patient with a lot of palpitations, chest pain, sort of cardiac or pulmonary symptoms, orthostatics are really helpful, especially in evaluating for dysautonomia or any sort of postural orthostatic tachycardia syndrome, and just in general to make sure your patient isn't too dehydrated. Almost all of them will get an EKG at some point to evaluate for arrhythmias or, again, unless they're quite older, ischemia. It's not uncommon if they're having a lot of palpitations to get something like a Holter monitor or an event monitor. Very, very rarely I've ordered an echocardiogram, either at rest or a stress echocardiogram. And then Personally, I don't typically order this, but this has definitely been something that I've seen among other post-COVID providers ordering a troponin, BMP, and D-dimer. I just feel like the chances of someone having an acute MI or being volume overloaded are very low, and that generally those wouldn't really provide a lot of additional information. I do find the D-dimer sometimes helpful in the context of the fact that like post-COVID syndrome and COVID in general increases the risk of blood clots. And for these otherwise low risk patients, a negative D-dimer might save me a lot of imaging, and I feel like that's worth it. It's also very common in these folks to get some type of pulmonary evaluation, especially if they're experiencing a lot of shortness of breath on exertion or some degree of cough. I would say the most common is just, as you guys would expect, your basic chest x-ray, although more often than not, I feel like a lot of providers end up getting a CT or a CTA, similarly again to rule out any sort of blood clot or any sort of more interparenchymal disease. PFTs have also been pretty common in these folks, just to evaluate it for any sort of baseline asthma, restrictive or obstructive lung disease. And then some clinics have been getting 6-minute walk tests. Although again, while it's published a lot in the literature, I haven't found that to be particularly effective, since most of my folks have been sort of between 30s and 60s and pretty otherwise healthy and able to do a normal walk test. In terms of neurologic evaluation, if you feel like this is appropriate, the patient's having a lot of brain fog or memory loss or difficulty concentrating, you can absolutely start with things like a MoCA or refer to speech language pathology for a formal cognitive eval. I've probably done that in about 5% of my patients. I would say most it's sort of more expected brain fog as opposed to true memory loss. If they're having a lot of orthostatic intolerance, you can absolutely refer them for a tilt table test, which can be done through neurology or technically cardiology as well. And then I always think about getting a PHQ-9 and GAD-7 in these folks to evaluate for any comorbid depression, anxiety, either that's present at baseline or may have been there to begin with, or maybe now as a result of their current symptoms. If you're really worried about paresthesias or new neuropathy in your patients, you can absolutely refer for an EMG, and the post-COVID clinic at Harborview, which I'll get a little bit more into, can absolutely do that for you. If the patient is having a lot of joint pains, synovitis, rashes, or gives you any flavor of autoimmune, it's not unheard of to get an ESR, a CRP, an ANA. If you're thinking specifically joint pain, an anti-CCP or an RF, or if they're having more myalgias, to get a CK. I would say this is absolutely not the most common workup we obtain, but I have ordered it before in patients where I feel like I'm really sort of maybe missing something in terms of their joint pains or their myalgias that I can't otherwise explain. But this is definitely sort of more on the extreme side of the workup. And then if a patient has a lot of gastrointestinal complaints, the majority of these seem to be more upper GI, things like pretty bad heartburn, reflux, epigastric pain, right upper quadrant pain. So again, not unheard of to get a lipase, a ruckus, H. pylori testing with a stool study or an upper endoscopy. But again, similar to the autoimmune, these are not things that I typically order for patients unless they have a fair amount of symptoms. And I'm more likely probably to like recommend an antacid and sort of go through this whole process. Because post-COVID can increase the risk of blood clots, coags are technically often listed in the studies as something that you're supposed to get. Again, I haven't really gotten this very much, but I know it's something to think about. And if you think for any reason someone might be a hypercoagulable state or higher risk, you can certainly think about getting that. But again, it's not really part of the normal workup. The big thing is there is actually no test for post-COVID syndrome. No matter what you've heard or all of the like weird post-COVID panels that exist out there, I have no idea how to interpret those. They make no sense to me. They're a bunch of like random antibody testing and they don't help at all in terms of the diagnosis. So I work really hard to convince my patients not to get these tests, but many of them may present to you with these and ask you to interpret them. And the honest answer is, I don't know. Like, they don't really provide any additional information, and they're not super helpful. So something to keep in mind, post-COVID syndrome is absolutely a diagnosis of exclusion. All right, before I sort of jump back into the case, any questions so far? Okay.
Sarah,
Oh,
a question just came
yes.
in. John is asking, how often do you do these tests and find another cause?
Ooh, John, this is a great question. So I often do these tests and I rarely find other causes. I have seen, at least in Seattle, the most common, probably because the majority of the patients presenting to me are women in their 30s to 50s, are either thyroid disorder, iron deficiency, B12 deficiency, or vitamin D deficiency, are far and above the most common four that present. I have only had one case of true autoimmune disease, and I've never really seen a metabolic panel or a CBC be abnormal. I've never had really a lot of significant cardiac disease. I've had one patient that presented who did actually have true asthma on their PFTs, and treatment was very quite helpful. And in terms of the cognitive dysfunction, it's almost always led back to some degree of depression, anxiety, insomnia, or PTSD related to their disease. So it's very interesting because we do a lot of this workup. And as you probably know, it's not particularly valuable because the majority of cases are just post-COVID syndrome. Does that answer your question, John?
Totally.
Let's see, Jordan, which makes me wonder, are we over testing in these cases? I'm just thinking back to the beginning of the talk. Yes. So I love my job. I love getting to be a primary care doctor. I love getting to meet these patients, but I am totally over testing in them 100%. And I feel like most of my job is to reassure these patients that they don't have something else. And the reason I'm doing this testing is just to make sure it's not something more serious. And the majority of the time, it's absolutely just post-COVID syndrome. And what I wanted to outline for you guys is, yes, these are the test options available, and you can certainly order them. But do we really need them? It's a good question. For folks that have a lot of insurance limitations or financial limitations, I don't order all of this. For folks where they really want this for reassurance, I will. So a lot more of my care is based on sort of patient preference and patient reassurance than like actually what I think is the most choosing wisely use of my resources. Does that answer your question, Jordan? Yeah. So not the best use of our resources, but right now, while it's not well understood, it is not uncommon to order all of these tests. And I would say in general, I tend to be a bit more conservative than actually a lot of my post-COVID colleagues who will do much more of the like shotgun approach of just like order all labs and see what happens. In this case, I had specifically gotten a metabolic panel of CBC because she never had one. I got a thyroid, and I'm a little bit heavy on the ferritin, B12, and vitamin D because I've generally found in young women, those are often abnormal, and treating those underlying low values can make a big difference in people's at least fatigue or brain fog. In this case, she'd had an ANA that I didn't order that was normal as well. I didn't end up wanting an ESR or a CRP. She had had an EKG, which showed just mild sinus tachycardia. I ordered a Holter monitor given her palpitations was also normal. She already had a chest x-ray and PFTs when I met her, both of which were normal. And then her MOCA for sort of a cognitive evaluation was 28 out of 30, to be expected, very normal. And then GAD-7 and PHQ-9 both showed some mild depression and anxiety. The big thing at this point was the patient really wanted to know if she had long COVID. And again, as I mentioned before, there's no good test for this. So it's more or less a diagnosis of exclusion. But based on this, I felt like it was very reasonable that her symptoms could be attributed to long COVID. And then sort of as expected, she was quite concerned that I was thinking this was all in her head and this wasn't actually real, as she was struggling to concentrate at work still and do her ADLs and IADLs. So one of the things that's really, really important in these folks is to focus on validating them and making them feel like this is a real disorder and part of something that we can explain, and helping them optimize their functional status and quality of life, and really reassure that what they're feeling is already well described in literature. Again, remember not to sort of bias your evaluation too much, because again, autoimmune disease is a common presentation in this age group, but really just making them feel like you actually hear them. This is not in their head, and this is an actual disorder that we can validate. For me, I often will talk a lot about here how things like chronic fatigue syndrome and myalgic encephalitis have been around for a while in terms of sort of the post-viral syndromes, and that post-COVID is more or less pretty similar to that. And that now we're just lucky in that post-COVID has caught more attention, has a larger population size, and so we're able to get more research, but it's still very preliminary in terms of how the pathophys is, in terms of treatment options. Which of course is her next question, which is, what are some potential treatment options? Any idea of treatment options for post-COVID syndrome? Has anyone heard anything? Are you all equally in the dark? I'll give you guys a minute to put anything in the comments if you've heard of. We always use gabapentin when we're mystified. Graded exercise, yes, absolutely. Symptomatic management like albuterol and inhaled corticosteroid, rehab PT. Dude, you guys don't even need me. You guys are totally spot on. This is fabulous. So my first plug, both because it's what I do and I love, and because I think it's your best resource so far, is you can place a referral in Epic, or for those at the VA, you can fax this over. We have a post-COVID clinic at Harborview that's been rapidly growing over the last 2 years or so. It was initially started by rehab medicine, but now includes a variety of internal medicine folks like myself and family medicine who assist rehab medicine in terms of consultation. So it's quite common for me to see a patient in conjunction with rehab medicine to evaluate for potential other causes and again, help with symptom management. We are incredibly lucky in that there are physical and occupational therapists who are trained specifically in post-COVID syndrome, and the graduated exercise recommended and different protocols for this. We have a speech language pathologist that can help both with rehab psych and cognitive rehabilitation. We have rehab psych, which is again, a gift in our system. And then also actually support groups. So many of my patients that I've seen have really benefited specifically from the rehab psych and the support group and the physical and occupational therapy. So keep this in mind. It's a very easy evaluation. The numbers overall are still pretty low. I'm probably, at least myself, seeing only a couple patients a week, and we're probably globally looking at a program of about 30 referrals a week. So if you guys have patients with this stuff and want to plug them in, please, we are like a growing clinic and we would love to see more patients. Other options, so all medical treatment options beyond speech language pathology, PT, OT are experimental. And these are things with fairly limited data, but I can say at least with my small sample size have been pretty effective. The first option that is surprisingly very low barrier and low side effect is actually the majority of patients respond really well to a combination of an NSAID of your choice and an H1 blocker. And by this, I mean like pick your favorite ibuprofen, naproxen, whatever it is, combined with cetirizine or with loratadine once or twice daily. And for some folks, this is like life-changing to completely reverse their symptoms. My best explanation is maybe it's sort of hand-wavy, anti-inflammatory, but again, something you can all do without really sort of any other education or experience. as long as they can have an NSAID, seems to be particularly effective. Some folks will add on an H2 blocker like famotidine as well as a third agent, and additionally that provides maybe like a little bit of benefit. Whenever people are having an acute flare, it's actually quite common for us now to suggest like a low dose steroid burst. This is most commonly prednisone, 10 to 20 milligrams for 5 to 7 days. And when people are really, really symptomatic, this tends to shut it down. The other place that I've commonly used this is when people have had a vaccine and had a really, really intense vaccine reaction. That's been quite helpful for them to get a little bit more into what the complexity is behind that. For folks with more fatigue, brain fog as their primary symptoms, cognitive rehab, especially through the post-COVID clinic, has been really, really helpful for folks who prefer non-pharmacologic options. In terms of pharmacologic options, I actually use a lot of the same medications that overlap with ADD, ADHD, which are bupropion, which has the added benefit of sort of the depressive component, as well as sort of the a little bit of energy that it can give and a little bit more focus. Atomoxetine, similar to modafinil, has now been studied in cancer patients, chronic fatigue patients, and has been found to be quite effective for brain fog, fatigue, sort of generally decreased energy. And it's thought to be, again, specifically because it increases norepinephrine and dopamine in the brain. It's also useful for folks who have a lot of dysautonomic symptoms because, again, of the increased norepinephrine. Modafinil, Provigil are, again, you guys are probably seeing these used in cancer patients, not unreasonable to reach for, although they are technically a stimulant. And then I probably have 1 or 2 patients that I've actually prescribed a low dose stimulant. And I primarily use this in folks who have failed the other therapies. But I have a couple who are on methylphenidate, like 5 milligrams once a day, maybe 5 milligrams twice a day. And for them, it makes a world of difference. And they've gone from being unable to work to completely back at full capacity at work. So for me, I feel like that was generally worth it. And then for folks who have a lot of dysautonomia, whether this is more the POTS syndrome or sort of other types of dysautonomia, there's already longstanding good evidence for use of fludrocortisone, proteostigmine, and a beta blocker. And then for those who prefer more non-pharmacologic measures, compression stockings, abdominal binders, or specifically focusing on increased fluid intake and increased sodium intake. For those that have a lot of exercise intolerance, again, you guys already picked up on this. The graded exercise is really sort of the key here, working with PTOTs who are trained in post-COVID syndrome and focusing a lot on pacing and energy conservation. If I were to recommend to a patient what exercise to do if they didn't want to do PTOT, I typically recommend things like a recumbent bicycle, rowing machine, or things like going to the swimming pool, where you have less resistance and less sort of need of the intense cardiovascular exercise while still getting some cardio in. Lower extremity resistance strength training is also really important in folks with a lot of dysautonomia because it helps reduce some of the venous pooling. If patients have a lot of psychiatric symptoms, you guys know this very, very well. Using SSRIs, SNRIs, or TCAs can be quite helpful. I would say in general, I'd probably reach more for the SSRIs for the pure depression and anxiety, and the SNRIs, obviously, if people have some degree of neuropathy or sort of other general pain. I haven't done TCAs as much in this group, although it's technically evidence-based that you could do that. Again, the post-COVID clinic has rehab psych as an option, support groups, counseling, and then there's always CBT. So if you can either refer to our clinic for that, or you can refer generally through Psychology Today for other folks that are out there. Sorry for that pop-up. For folks that have a lot of shortness of breath, chest discomfort, or pulmonary symptoms, pulmonary rehab has been really helpful. And as one of you guys pointed out, I see who was that here, Rima mentioned, there's actually good data similar to the new guidelines for managing asthma for trialing inhaled corticosteroid plus a LABA, so like Advair, for example. And that for a lot of these folks, using that either as needed or regularly can be quite effective. And then based on the theory that most of the post-COVID syndrome symptoms are more like nerve hypersensitivity. For folks that have a lot of pulmonary symptoms, sometimes gabapentin can be quite helpful, which I think was something that John had mentioned earlier is all general fix all. Yes, gabapentin fixes a lot of post-COVID syndrome. And then interestingly, you guys all probably have heard about the loss of smell and taste related to post-COVID syndrome. And while most folks regain their sense of smell, some do not. And for those that have lost their sense of smell, there's actually really good data to refer them to ENT on the earlier side, so that they can do olfactory training, which is basically when they have patients smell different compounds and record their response, or smell different odors associated with a specific picture to try to bring their sense of smell back. And if they do that earlier in their disease, they're more likely to actually regain their smell than those that don't. And then there's maybe limited data for inhaled corticosteroids. It's certainly worth trying, but probably isn't super effective. And then again, sort of relating back, those that have a lot of joint pains, myalgia, there's good evidence for either scheduled NSAIDs or prescribed NSAIDs like meloxicam, indomethacin, sort of whatever your favorite is, or again, short bursts of steroids on the low end sort of help with those symptoms. And I would say finally, the last most important thing in terms of treatment is you can offer disability support to these patients. So post-COVID is now recognized by the ADA, and you can do things like FMLA paperwork, specific work accommodations for these patients, or different types of support letters to help so that sort of those that either can't work from home or need reduced work hours or need reduced physical labor can actually get support and be able to continue to be employed despite their symptoms. And you can do this for 3, 6, 12 months if you need for these patients. Now, this is the most complicated issue, which is technically all of the studies say vaccinate these patients. It's super important. It reduces the risk of long COVID. It reduces the risk of more severe infection with a secondary infection like my patient had. But I would say this is a pretty complicated issue right now. And that's because my personal experience with my population of maybe 20, 30 patients has been that vaccines are really variable. Some folks get the vaccine and their symptoms are resolved and they feel amazing and they complete their full series with no issues. I have others that get the vaccine and have horrible flares to the point that they're almost more incapacitated than when they actually had COVID and never make their way to getting the second vaccine. And I have others who are just too scared to even consider it. My personal approach has been, if a patient for some reason can't tolerate a vaccine or is worried about it getting a vaccine, I write them letters to allow them to not be fully vaccinated and to support them through that while continuing to advocate for it with time in the hopes that eventually we can, or trying to find ways to treat them through their flares so that they can then get the second vaccine. But I don't personally hold back in terms of writing letters to support these folks if they can't get the vaccine. Ooh, John, interestingly, I had thought that there were data to suggest that unvaccinated individuals who had long COVID would benefit. Yes, so theoretically, the data says that like the vaccines can actually be beneficial in terms of reducing their risk of recurrent infection, reducing their flares, and potentially even reducing their symptoms. And I've had a few that have like gotten the vaccine and like that was it, their symptoms resolved. But what's really interesting is in practical application, more folks I've seen, at least again in my small sample size, have had worse symptoms after. And so I've had to sort of deal with that in real life and help them through their flares, even if maybe the majority of the population has generally done better. Does that answer your question, John?
Yeah, it's sounds like it's a very nuanced and very challenging conversation. I would I can't help but think of the overlaps between long COVID and fibromyalgia in some ways, and so I hear a lot of echoes in some of the things that we're recommending and things that we're talking about. So it just shapes the way I'm thinking about this.
No, John, you are spot on. As someone who also cares for a lot of fibromyalgia patients, it has been very difficult to convince them to get vaccinated because the majority of them know that their symptoms will be worse when they're vaccinated, but in the long run, it will reduce their risk of more severe syndrome and more severe symptoms. But convincing them to do that has been quite a barrier. And I feel like I've hit something very similar with many of my post-COVID folks. All right, so does anyone know how long this patient can expect to be experiencing symptoms and what the disease course is with post-COVID? I will take some suggestions in the comments if anyone has any idea. Jason, thank you. Your answer is absolutely fantastic. And I won't even actually ask for any more after that because it was such a good first answer. Yes, the honest answer is we have no idea whatsoever. I've been working with the post-COVID clinic for about 1.5 years now, and I have some patients whose symptoms have resolved at 3 months and some that we're now 1.5 years in, where I'm happy that they have 5 symptoms instead of 10 symptoms, and we're like slowly making progress. So we truly don't know. We know folks that were either in the ICU or hospitalized are always expected to have a much longer disease course. But we have really good data that even people with very mild symptoms are just as likely to have as long of a post-COVID course as those that were otherwise in the ICU. So it seems to be something related to the host substrate, but again, we don't really know what that is. Again, about 1.5 years into doing this, I would say my experience has been most people are better by 6 to 12 months. On the early end, as good as 3 months. Like for example, I had one patient who was a pilot who was unable to fly for quite some time, and at 12 months post-disease was able to go back to fully working for Alaska again as a pilot, passed all their cognitive evaluations. I have another patient who I've been following for 1 year who has had a lot of issues with respiratory symptoms and GI symptoms that have more or less just resolved. And now she's back to running pretty regularly, which for her was a big accomplishment. But it's very person specific. And then of course, there are the rare patients, sort of like chronic fatigue syndrome or myalgic encephalitis, symptoms don't go away. I would say with post-COVID, I haven't encountered that yet, but again, we're only about a couple years into this. I've seen more people generally improve than truly be sick long-term. So I'm hopeful that that's actually the case. There's some data that folks who are hospitalized, about 52 to 87% still had symptoms for greater than 2 months, up to 12 months. And of the outpatient cases, about a third had not returned to baseline by 3 weeks, and about 40% has still had persistent symptoms at 7 to 9 months. But again, this data is very limited and very preliminary. So overall, what I want you guys to take away from this is that post-COVID syndrome is more common than you might think. It presents basically with any symptoms it wants to, but generally symptoms pretty similar to the actual acute illness, and can last for an unknown duration, but is at least 4 weeks beyond initial presentation and longer than expected. And we can absolutely treat this, but it does require multidisciplinary approach, and there are a lot of management options. So please, please, please refer these folks to the post-COVID clinic or myself if you have anyone with these issues. Do you guys have any questions before I hand this over to the next speaker? How do referrals get entered into EPIC? So you just type in post-COVID and it comes right up, and you can just refer over. From folks from the VA, it depends on their extra VA coverage, but you can generally fax the referrals over as well. Gina, I've got to mention that there is very little data on this, but are there anything, variants, yes, this is really interesting, Gina. So I've actually seen more referrals post Omicron than I did pre Omicron. We went from like 1 or 2 a week to our population seeing as many as like 40 referrals in a week post Omicron. And I had sort of expected Omicron not to cause as much like post COVID syndrome because it was so much milder. But again, the overlap with the mild disease suggests that that's not necessarily the case. And actually, our rates have like blossomed beyond belief. And the clinic's been open since I think late 2020. And I honestly see more referrals now than I ever have. And I'm sorry to mention this, but do you know if vaccine folks who get COVID? Oh, yes. So Anna, great question. Yes, if you're vaccinated, you are less likely to get long COVID. It doesn't completely prevent it, but it can reduce the risk by about 50% as much. And so it's really, really important for anyone who's high risk for long COVID, people who have fibromyalgia or already have chronic fatigue, to get vaccinated because they are very, very likely to get post-COVID in the long run. Other questions before I hand back to Nina?
Great. Thank you so much, Sarah.
Thank you guys all for listening. I hope it was helpful.